Good afternoon and welcome to the DRUGSCAN oral fluid testing webinar. We'll get started in a minute or two as people are still joining. Thank you. All right, good afternoon and welcome again to the DRUGSCAN oral fluid testing webinar. I'm Mike Romanecki and I'm the Senior Vice President of Business Development for DRUGSCAN. I'm pleased to have you join us today for an informative webinar. All participants will be on mute, but if you have any questions, please submit using the chat function in GoToMeeting. We'll hold any responses until the end and provide an opportunity to ask additional questions at the time. We'll also post the slides and a recording of the webinar to our website, drugscan.com, in a couple days. At this time, I'd like to introduce our speaker today. Deb Botica is a Senior Vice President and Lead Toxicologist for DRUGSCAN. She has over 40 years of experience in the drug testing industry. So Deb obviously has started at a very young age for her career. She is certified by ABFT, the American Board of Forensic Toxicology. She's also on the Drug Testing Advisory Board for SAMHSA and the Opioid Task Force for Berks County. She's become a leading speaker for clinical organizations and universities in regards to drug testing, and I'm pleased to have Deb available to speak with you today about oral fluid testing. With that, I'll turn it over to Deb to get things started.
Thank you, Mike. And thank you all for joining today in our second presentation on oral fluid testing. The objectives today are listed on the screen. Identify the role of drug testing using oral fluid as a matrix, specifically discuss the Quantasol oral fluid collection device, and talk about the unique features of identifying drugs and metabolites in oral fluid. My goal is for each and every one of you to walk away from today's oral fluid webinar knowing a little more than you did yesterday. Interesting to look at the different matrices as a global examination of the windows of detection. So looking at hair, blood, urine, and oral fluid, all of which are routinely analyzed today in the United States. DRUGSCAN's primary focus is on urine and oral fluid, although we do perform some blood testing. This is a presentation of the different detection windows of hair, urine, saliva, and blood, and I'm also including sweat in this slide. Though sweat is a relatively new matrix that a lot of analysis is being performed on as far as doing studies looking at the differentiation. Another representation is this slide where we're looking at the differences now, adding breath in the testing matrix. Historically, breath has been used pretty much exclusively for breath alcohol testing, which we know it is a very good matrix, and very many of the police departments across the country use breath as an indicator of inebriation. And now you're looking at breath versus oral fluid versus blood, urine, and hair. Both breath, oral fluid, and blood begin to rise upon the ingestion of a certain product, with the breath having the shortest window of detection, up to 2 to 3 hours, with oral fluid have a typical window of detection up to 24 hours, though we will discuss some drugs that have a longer window detection than that. Blood may be up to 3 weeks. Urine for certain analytes up to 1 month, typically most analytes 2 to 3 days, and hair, which the detection does not begin immediately, but takes anywhere from 6+ days for the drugs to get deposited and show up in the hair follicle. Now to get on to our primary matrix we want to talk about, which is oral fluid or saliva. As you can see from this rather busy slide, oral fluid is made up of many different particles that accumulate within the mouth. We're not going to talk about all of those in detail, but just know that the primary producers of oral fluid are the parotid, submandibular, and sublingual glands located in the mouth. Oral fluid and drug deposition, highly perfused salivary glands and oral fluid cavity tissues allow rapid transfer of drugs from blood to saliva. So what does that mean? That means that, generally speaking, in order for a drug to be identified in the oral fluid, they transfer from blood through the salivary gland and end up in the oral fluid. This transfer occurs primarily from passive diffusion, which means that it doesn't require any particular mechanism in order to get from the blood into the oral fluid. But there are factors that regulate how and when this happens. One of the most important ones is the chemical properties of the drug. Another factor is the salivary pH. Another is whether or not the drugs are lipid soluble. Lipid soluble, primarily the parent drugs, will diffuse passively from the cell membranes into the oral fluid much more easily than their metabolites. Which that means is we have a tendency to find the parent drug more commonly than the metabolites. Another important factor is the concentration of the unionized drugs. So drugs exist in different forms in the blood, ionized and non-ionized. The ionized forms of the drugs do not passively diffuse. Therefore, we should typically just see the unionized drug forms in the oral fluid. Another factor is drug protein binding, because only free drug can diffuse. And as you'll see as we talk about some of the drugs in particular, highly protein-bound drugs will not transfer as easily. Another factor that I don't have listed here, but individual differences in protein levels will affect the amount of protein binding, therefore the amount of drug that can cross into the saliva. So there's a lot of factors. Collection of oral fluid. There are many advantages to the oral fluid collection. Simple collection is an important factor. The fact that it is a non-invasive collection. There's no need for special restroom facilities. You can collect it in virtually any location. No need for same-sex collectors for observed collections, as we do now for urine collections. Can be performed under direct observation with the person sitting in a room across from you, or one of the newer techniques out now is video monitoring, and we'll talk a little bit about that later on. There is a risk of reduced adulteration and substitution, and it will identify recent drug use. Immunolysis oral fluid collection video will be available to those of you watching the presentation today by just clicking on this slide when the website is posted. Oral fluid collection disadvantages, and unfortunately there are some disadvantages. Some drugs, particularly individuals on high-dose opioids, may have reduced salivation. This reduced salivation will result in reduced volume of oral fluid collected, or it may take a longer collection time. Will the reduced volume affect the measurement of the drug? Yes, because of the limited volume. Drug concentrations are frequently lower in oral fluid than in urine because drugs will accumulate in urine over a period of time, whereas oral fluid will pretty much be a snapshot in time of the collection of the oral fluid while the drugs are circulating in the blood. As we mentioned before, not all drugs cross into the oral fluid. Drugs that are smoked, inhaled, or taken orally may contaminate the oral mucosa, therefore the oral fluid, may lead to increased detection rates, and result in reduced correlation with blood concentrations. Saliva is relatively acidic, so this is another factor that will influence the transport of drugs across the oral mucosa. Acidic meaning that basic drugs will be found in higher concentrations in the oral fluid than in the plasma because they have a tendency to cross into the oral fluid much more quickly and much more easily. Amphetamines and cocaine are two examples of these drugs. Oral fluid detection times are most useful in detecting recent drug use. As drugs leave the blood and are distributed to their sites of actions and the different areas in the body where the drugs reside, they're no longer circulating. Therefore, the drug detection window is more narrow. Some drugs and some metabolites can be detected for a period of several hours up to a couple of days. Drug levels, generally speaking, are related to blood levels. We'll talk a little bit more about that more specifically as we move forward in the presentation. Drugs, important to note, may be present as residual drugs in the oral cavity. So if somebody's administered Suboxone sublingually, which of course is naloxone and buprenorphine, those drugs will reside in the oral cavity, not as a function of transport from blood into the oral fluid, but as a deposition of the drug from the administration. You'll also see that for drugs that are smoked, such as marijuana. This is a slide I really like to use because it talks about the average oral fluid to blood concentration for ratios of certain drugs. Reference, if you're interested in looking for more information about this, alcohol, ethanol is a very close correlation between oral fluid and blood. Oral fluid is used commonly as a saliva alcohol screening test in certain circumstances. As you see, barbiturates have a low oral fluid to plasma ratio, which means that the level detected in oral fluid will be less than we find circulating in the blood. Buprenorphine one, codeine, which is basic. We said basic drugs transfer into oral fluid with a greater degree, has a ratio of 4:1. And as we go down. Identifying drugs and metabolites. We're now going to talk about some of the drugs we routinely identify in oral fluid and how do you interpret what you see as reported concentrations and parent and metabolite ratios. Amphetamine appears very rapidly in oral fluid. It typically parallels plasma drug concentration. The risk of a positive from passive exposure appears very unlikely. Possible sources are typically prescription ADHD medications such as Adderall and Vyvanse, and it's also present as a metabolite of methamphetamine. Methamphetamine also appears rapidly in oral fluid. It can be abused by numerous routes, including smoking, snorting, injecting, and oral administration. It too parallels plasma drug concentration. Risk of a positive from passive exposure appears unlikely, and it may be present along with amphetamine as its metabolite. Benzodiazepines are lipophilic drugs with high plasma protein binding. And if you remember what we talked about early on in the slides, high plasma protein binding causes less drugs to transport into the oral mucosa. Generally weakly acidic, again, another factor which causes lower oral fluid detection. Blood and oral fluid levels peak at approximately 3/4 of an hour, and it does not correlate well with blood concentrations. Those that we can't find in the oral fluid, typically you'll see approximately 88 to 197% correlation with blood, and they differ amongst the different benzodiazepines. Cannabis smoking is the primary route of administration, though now as legalized marijuana is becoming more prevalent, ingestion and production of edibles is becoming more of a desirable route for many people. THC found in oral fluid following both smoking and oral ingestion of cannabis. Both of them can be found very early on following the smoking and ingestion as a drug deposition. Marijuana levels identified in oral fluid. Typically, THC is identified following smoking and oral ingestion. The THC carboxy metabolite may be found in very low concentrations. Extremely high THC levels are found immediately after smoking and decline very rapidly. And recent studies indicate that passive inhalation did not produce false positive oral fluid tests. Within the past several years, there was a belief that oral fluid levels can be positive based on passive inhalation, but as some new studies were performed, we found that it was contamination during the collection process that indicated positive oral fluid levels, and not necessarily, we know now, from passive inhalation. Hang on, my computer is misbehaving. Cocaine has a short, approximate 1 hour half-life. It's rapidly hydrolyzed to its metabolite, benzoylecgonine, abbreviated BZE. Cocaine and BZE show up very rapidly in oral fluid following all routes of administration, and oral fluid levels decline rapidly. BZE and cocaine levels in oral fluid. How do we interpret what we see on a report? If the cocaine is positive and the BZE is negative, it generally speaking indicates use within approximately 8 hours. Positive cocaine greater than BZE, likely the individual used it within the past 2 to 8 hours. Positive cocaine results less than the benzoylecgonine results can typically mean two scenarios. They are occasional users who use cocaine likely within the last 12 hours, or cocaine use likely within 48 hours for those individuals who are chronic daily users. When BZE levels are reported positive with no cocaine present in the oral fluid, that's likely use within 48 hours for occasional users, and for those daily chronic users, 48 to 96 hour use. Opioids such as heroin. Heroin is the drug diacetylmorphine. It's most commonly administered intravenously or smoked. Very short half-life. It's rapidly converted to 6-acetylmorphine, abbreviated 6-M. The 6-M will appear in oral fluid within 2 minutes following all routes of administration. The levels we find in oral fluid are very similar to blood when the IV route is used. Higher levels in oral fluid following smoking, most likely because of oral fluid deposition. 30 to 60 minutes after smoking heroin, oral fluid levels diminish and reflect blood, though I'm going to talk a little bit about later on a study that seems to disprove this. Opioids, heroin levels in oral fluid. So if you're looking at the data and you find a positive 6-acetylmorphine and morphine on a report, that's indicative of heroin use. If the morphine is positive only, that does not rule out that the individual ingested heroin. It just may mean that the 6-acetylmorphine is no longer present. It may also mean possible poppy seed ingestion within the last hour. During yesterday's webinar, an individual asked me exactly how much poppy seed would someone have to ingest in order to give a positive oral fluid morphine. I think everybody would like to know the answer to that. We don't really know that right now. Many studies have been done, and the concentration of morphine in different batches of poppy seeds differ greatly. If you see a positive morphine and codeine on an oral fluid report, if the codeine is greater than morphine, it's indicative of codeine use. If the morphine is greater than codeine, it may be heroin, or it may be the individual is taking morphine. Now, in this case, the codeine may be the impurity in the heroin production, because we always, or almost always, see the same scenario when we evaluate urine results in individuals who are positive for heroin use by the presence of 6-am in urine. We see codeine not as a metabolite of morphine, but as an impurity in the production of heroin. We also see the codeine based on poppy seed ingestion. Morphine will appear rapidly in oral fluid. Now, morphine has a very high degree of glucuronidation. Drugs that are highly glucuronidated, generally speaking, will not transfer very easily into the oral fluid. Patients on morphine, we typically see high levels of morphine in the oral fluid. We know now it's because of the dosing and not necessarily the fact that the high protein binding decreases the amount of drug. So that was an interesting piece of information that I identified during my research. So it's the dosing that affects the levels. Following parenteral administration, morphine will also appear very rapidly in oral fluid. Morphine may also be a metabolite of heroin, codeine, and a natural component of poppy seeds. Morphine levels in oral fluid. Positive morphine, and you're saying to yourself right now, boy, she's repeating herself. I am, because the opiates have a tendency to cross over within themselves. So I'm happy to say them multiple times so that we see how intertwined they are. So positive morphine, it may be heroin, morphine, or poppy seeds. Poppy seed ingestion may result in low concentrations up to 1 hour after the consumption of poppy seed containing products. Codeine use has not been reported to produce detectable morphine levels other than very low. Again, this is the indication of the codeine being metabolized, the morphine being highly protein bound. If you see positive morphine and 6-am, it's indicative of heroin. Positive morphine and codeine, morphine greater than codeine, maybe heroin, or combined morphine and codeine use. You'll have these slides to refer to if I'm confusing with you, which I apologize. 6-acetylmorphine in oral fluid. This is that slide I mentioned I wanted to talk about. So we have believed that positive 6-am may be detected in oral fluid for about 8 hours, and urine approximately 34.5 hours after use. A recent study by Vindies showed that 6-am was detected in oral fluid 4 to 8 days after use of heroin, while it was undetectable in urine and the oral fluid morphine levels were negative. So that's been very interesting information, which challenges everything we believed about heroin use and 6M in oral fluid. Therefore, oral fluid appears to be a great matrix to identify individuals using heroin. Codeine, oral administration will result in levels within an hour with maximum of 1.6 to 1.7 hours. Levels typically are 3 to 4 times higher in oral fluid than plasma. Codeine metabolizes to morphine. You will detect that in urine. We will not, generally speaking, see a lot of them, codeine, metabolize morphine in oral fluid, as we just mentioned. Codeine is detected in oral fluid following intravenous and smoked heroin administration and poppy seed ingestion, but not following codeine administration. Codeine levels in oral fluid. Positive codeine is indicative of codeine use. Positive codeine and morphine. Morphine greater than codeine, possible heroin, or secondary codeine use in combination with morphine ingestion, or again, poppy seeds within an hour. Hydromorphone. Oral administration of hydromorphone, you will see plasma levels peaking in approximately 1 hour, and it will appear in saliva relatively rapidly after that in both oral and intravenous administration. Hydromorphone levels in oral fluid. If the hydromorphone is positive, it's indicative of hydromorphone use. If we see positive hydromorphone and morphine being present in the oral fluid results, hydromorphone greater than morphine, that's indicative of both hydromorphone and morphine ingestion, because hydromorphone does not metabolize to morphine. Hydromorphone levels much less than morphine, that's possible hydromorphone use, or the hydromorphone may be showing up as a minor metabolite of morphine, but that scenario occurs only very rarely. Hydrocodone, primarily misused by the oral route, may be abused though, or used intranasally, smoked, or rectally. Reaches a plasma maximum in approximately 1 hour. Hydrocodone levels in oral fluid. Positive hydrocodone with no hydromorphone or codeine means the individual used hydrocodone. If we see hydrocodone and hydromorphone, where hydrocodone is greater than the hydromorphone, it's indicative of hydrocodone use. Hydrocodone levels in oral fluid less than hydromorphone, it's likely a combination of the individual using both hydrocodone and hydromorphone. You may see very low levels of hydrocodone and hydromorphone at the end of the metabolism and excretion cycle. Positive hydrocodone and codeine. Hydrocodone greater than or equal to codeine, indicative of combined hydrocodone and codeine use. Hydrocodone, where the values are much less than the codeine, possibly the individual used hydrocodone in addition to codeine, but most likely it's the hydrocodone being present as a minor metabolite of codeine. Those of you that are familiar that looking at urine drug test results for individuals who have used codeine, a vast majority of the individuals using codeine will show low levels in urine of hydrocodone, norhydrocodone, and possibly hydromorphone. This is the same scenario where we may see some hydrocodone in individuals using codeine. Oxycodone, oral fluid levels are closely related to blood levels more often than urine levels. In one setting using 23 pairs of samples, the median concentration in oral fluid was 524 micrograms per liter. Blood was 53 micrograms per liter. projecting an oral fluid to plasma ratio of 12, which means that you'll find 12 times the concentration of oxycodone in oral fluid than you will in blood. It will appear in oral fluid and blood within about 15 to 30 minutes after oral administration. Positive oxycodone in an oral fluid result means the individual used oxycodone. If you find oxycodone and oxymorphone, where the oxycodone is greater than the oxymorphone, this is indicative of oxycodone use, where the oxymorphone is a minor metabolite. Oxycodone is less than the oxymorphone, it's likely the combined use of oxycodone and oxymorphone. But you may see the oxymorphone low concentrations toward the end of excretion following oxycodone. It's the same as finding hydromorphone at the end of the excretion following the ingestion of hydrocodone. They follow the same pathways. Oxymorphone by itself is excreted at very low levels in oral fluid. If we do find a positive oxymorphone, generally speaking, it's going to be oxymorphone use. May be present in low concentrations following oxycodone. More likely than not, it means that the individual did use oxymorphone. This is a conversation that the clinician has to have with the patient and consult with DRUGSCAN if they're interested in taking a little more dive into the data. Fentanyl. Oral fluid levels of fentanyl are fairly well correlated with the respective plasma concentration. Oral fluid plasma ratio of approximately 3.0 has been reported. And I have an interesting anecdotal story to tell you about oral fluid fentanyl that happened at DRUGSCAN. Took a call from a clinician asking about some what appeared to be absurd fentanyl results on one of his patients. And I actually had been familiar with the results prior to the clinician calling, because when the certifying scientist was about to release these results, they came to me to approve it because it was an unbelievably high level of fentanyl. So we had run it multiple times, had good data. I told them to release it. Clinician called up and said, "What do you think?" I said, "Well, I don't really believe that any individual having this type of oral fluid fentanyl could possibly be living." So he said, "What do you recommend?" I said, "Well, I recommend you do another collection, and this time, inspect the individual's mouth to make sure that he didn't place fentanyl patch in his mouth prior to collection." He said to me, "Well, why would someone do that?" I said, "Because they are most likely diverting the fentanyl." And he said, "Diverting?" I said, "Yes, they're selling it." I said, "Okay, thank you for that information." So we did get another sample, and this one too was greatly elevated. Clinician, I called him this time to discuss it, and he said to me, I really looked in this gentleman's mouth and I didn't see anything, so I'm really confused. I said, "Well, I can tell you that I still don't believe that these values are consistent with someone taking the drug." He said to me, "I find this very disturbing because I just found out that this gentleman's brother recently died from a fentanyl overdose." And I said, "Yes, that concerns me too." He said, "Well, I'm going to take a deeper dive into this." So he did find out from the family members a few weeks later and called me back to share that one of the gentleman's siblings told the provider that the patient was placing a patch, a fentanyl patch, underneath a partial denture that he was wearing, and that's how he was getting the fentanyl and selling it. So to say that oral fluid samples cannot be adulterated, believe me, these very smart individuals who look to divert their drugs can come up with some unique scenarios on how to do it. So looking at the levels and understanding oral fluid plasma ratios are very important to the clinician. And again, I encourage the offices to reach out to DRUGSCAN for help in looking at the data. Methadone and the major metabolite EDDP appear rapidly in oral fluid and correlate with plasma concentrations. Positive methadone, no EDDP, indicates that the individual used methadone within 24 to 48 hours, or they could possibly have placed the methadone in their mouth, just like the individual placed the fentanyl in their mouth. Positive methadone and EDDP is indicative that the patient used methadone within 24 to 48 hours. Buprenorphine, quite often administered as the formulation Suboxone, that has both buprenorphine and naloxone in the sublingual patch. Unfortunately, this shows a high level of buprenorphine within a few hours of administration, and that's because the drug, like we said earlier, will be deposited in the oral fluid mucosa, though it is still a good matrix for doing Suboxone treatment as long as the provider is aware of the risk of measuring the drug as deposition and not necessarily as transfer from the oral mucosa. Finding positive buprenorphine in oral fluid is indicative of buprenorphine use. Positive buprenorphine much greater than the norbuprenorphine indicates acute buprenorphine use. Buprenorphine less than or equal to the norbuprenorphine indicates chronic buprenorphine use. Switching gears a little bit, that was basically all of the drugs I was going to talk about today. It's important that we talk about what is happening now because of COVID-19 and substance use. The current situation highlights the potential for increased drug use. This morning on the news, as I was watching it, a gentleman was on one of the major news programs talking about how the addiction treatment centers are lacking a little bit right now in the attentiveness to the drug testing, and what they're finding is that the patients are using much more drugs and alcohol than they had because of the confinement. Unfortunately, there's less monitoring, but we now see that that may be breaking, which would be a good thing. There's more boredom in those individuals that have substance use disorder means they may use drug more. And interestingly, those individuals that are tobacco, marijuana, or vape drugs, or smoke drugs like crystal meth, they are higher risk for the COVID-19 very serious implications. And that because the virus attacks the lungs. So when you get an opportunity, very interesting, that this is data that just came out from NIDA probably early last week about COVID-19 and drug use. I highly recommend all of you to take a look at that website and read about it. This is a slide I like to share whenever I give a talk to any audience, really. Now, it is data from 2013 and 2014, but SAMHSA published it again in 2017. This is prescription pain relievers being used non-medically by individuals. Where do they get their drugs from? So 50.5% of those individuals get them from a friend or relative for free. 22.1%, again, using them non-medically, get them from one doctor. Yes, we still have problems in this country with pill mills. It's a lot better than it had been, but we still are seeing that across the country. 11% of the individuals buy them from a friend or relative. 4.4% of them take the drugs from a friend or relative without asking. 4.8% buy the drugs from a drug dealer or another stranger. 3.1% will get them from more than one doctor, and the other 4.1% are many other different reasons. And again, this is interesting data, really at the basis of a lot of the problems we have in the country as far as the drug crisis and diversion of drugs. I also wanted to talk a little bit about ASAM, which is the American Society of Addiction Medicine, and what their drug testing guidelines are. And I personally found this rather interesting. Drug testing should be used to explore denial, motivation, and actual substance abuse behavior. Test results that do not align with patient's self-report should generate therapeutic-based discussions with the patient. In addition to measuring the efficacy of the treatment for those individuals within an addiction program, drug testing may also serve as a motivation and reinforcement for abstinence. I found that to be very profound and not as relevant as I'd like it to be. Providers should use negative test results as a source of encouragement. Providers should persuade patients to the extent possible that drug testing is therapeutic and not punitive, to try to avoid an us versus them mentality. Many individuals in programs who are required to give urine and now more often oral fluids really do look at it as a punishment. And this is something that ASAM is trying to change. And another very important piece of information that I found that I'd like to share, and I will share more and more with all the individuals that I speak to, testing that will inform a provider of an irreversible clinical decision should never be based on point of care testing or screening presumptive positive results alone. Now, this is ASAM guidelines. ASAM states that formal laboratory analysis, which means quantitation based on confirmation of drugs present, is the gold standard. And I can tell you that this has hit home to me many times throughout my career, both in the hospital realm, where a lot of the probation, children's services, parole were using point of care and basing decisions onto an individual's life and livelihood on point of care alone, to the degree where they would get a positive opiate on a point of care and put someone in jail. Or more recently, I got a call from a probation officer who was handed a subpoena to testify in a case where one of her individuals that she was supervising, where the probation officer acted on a point of care fentanyl result and took the woman's children away from her based on that presumptive positive point of care fentanyl. She was now going to court to try to testify as to what facts she had that the woman was really using drug, and she was asking me for my help. And the only thing I could tell her is that presumptive positives are not the gold standard and you cannot rely on them. So the fact that ASAM talks about that in their drug testing guidelines, I found that very profound. Another ASAM bullet point that I decided to share with the group is the ability to consult with laboratory staff when needed is an important consideration in choosing a laboratory. The relationship between the testing laboratory and the addiction treatment center should be collaborative. Providers should be able to communicate with the testing laboratory about test panels, detecting sample tampering, test result interpretation, and regional drug use trends. This is something that DRUGSCAN is very much devoted to. I and the other toxicologists, thank you very much for their work, spend a lot of time talking to providers, helping them, assisting them in interpreting of drug test results. And the fact that ASAM mentions that that's a type of laboratory that providers should partner with, I'm proud to be a member of DRUGSCAN staff. Another information about another organization, ASRA, or the American Society of Regional Anesthesia and Pain Medicine, have also recommendations during the COVID-19 crisis. They're recommending telemedicine to evaluate and continue opioid prescriptions. They want to ensure that the individuals continue to get their prescriptions to avoid withdrawal. They have to provide naloxone education and prescription for naloxone for high-risk patients. DE registered practitioners can issue prescriptions for patients without in-person evaluation only if, number one, it's a legitimate medical purpose. Number two, audiovisual, real-time, or two-way interactive communication system can be put into place and in accordance with applicable and federal state laws. These recent guidelines are beginning to change and give some positive twists in the industry that we're all working in. And with that said, I'd like to close mentioning some of DRUGSCAN's important certifications. We are SAMHSA approved laboratory. We are also approved by the College of American Pathologists and hold numerous state certifications, including New York State certification. If anyone has questions, please place your questions in the chat function. And with that, I'd like to also mention that available will be the oral fluid DRUGSCAN screen and confirmation current test mix, including methodologies and levels, knowing that we're always trying to increase our test mix, and we will be editing these things in the near future as we bring more drugs online. And with that said, I'd like to turn it over to Mike. Thank you all for your attention. And as like I said in the beginning, I hope you walked away learning a little more than you did 47 minutes ago. Thank you.
Yeah, thank you, Deb. As Deb mentioned, please submit your questions via the chat function in GoToMeeting. And as we're waiting for questions to come in, I want to make you aware of a new service being offered by DRUGSCAN. As stated earlier, with the current pandemic, there's been a significant increase in telemedicine, and we're going to be offering a new solution that we're calling DocTox to help facilitate oral fluid collection that's monitored by DRUGSCAN staff, or we can provide kits to customers to facilitate an oral fluid collection during a telemedicine visit. So it's going to enable you to drug test your patients without having them in the office in a HIPAA-compliant, secure manner. And if you have any questions about the service, please reach out to your DRUGSCAN sales rep for more information, or you can email us at speaktoarep.com. Again, if you have any questions, please go ahead and submit them via the chat function. We took quite a few questions yesterday, and Deb's more than happy to respond to those. And with that, I'll turn it back to Deb to see if we have any questions.
Let me think about some questions I had yesterday that I thought were interesting. An individual discussed, do we currently have a test for alcohol measurement in oral fluid other than ethyl alcohol, which is currently the standard of alcohol testing? There's some studies now looking at ethyl glucuronide and ethyl sulfate in oral fluid, and it appears to be that ethyl sulfate may be an indicator that's useful in monitoring alcohol ingestion in oral fluid. The ethyl glucuronide molecule looks like it may be too big to cross over into the oral fluid, but perhaps the ethyl sulfate may be a marker. So more to come on that. Well, with no other questions, Mike, any last words you'd like to talk about?
Yeah, I guess if there are any questions that come up, please certainly reach out to us. We'd be happy to help facilitate those questions that happen after the webinar. With that, I'll just say thank you for joining the DRUGSCAN oral fluid webinar. As mentioned, we'll post the slides and recording to the DRUGSCAN website in a few days. Deb, anything else come in?
No, nothing. But
Nope.
again, thank you again for attending.
I think one did just come in there, Deb. Can you see it?
It just says thank you.
No. Well, you're welcome.
Thank you
With
very
that,
much.
we'll conclude the webinar, and thank you and have a great day.